good morning, guys. So as you know, my name is Brittany Jackson, and I am a student at Western Carolina University in the bachelor's degree program for emergency and disaster management. And this video is going to be for my communications 201 class, and we're going to be talking about stroke screens and the differences between different types of strokes, how to use those stroke screening scales as a diagnostic tool. So by the end of this lecture, what we hope is that you know and understand the difference between ischemic and hemorrhagic strokes, how to use the most common types of pre-hospital stroke screenings, and what we can do as far as a diagnostic tool to use those, and what that information actually means. So something I want you to keep in mind here is that this, according to the CDC, which is the Center for Disease Control, someone in the United States has a stroke every 40 seconds. Now that doesn't necessarily mean that that stroke is going to kill them. In fact, also according to the CDC's data, they say that someone will die every 4 minutes from a stroke, which makes it the 5th leading cause of death for Americans. But still, that 40-second number, just the fact that you're having a stroke, is huge, because not necessarily are we going to die from that, but we are going to, you could potentially have neurological deficit, could have a lot of issues ongoing from that. So looking at the two different types of strokes, and so like I said, you guys have covered the neurologic material in your textbook, and so bringing this in, you should be familiar with this, but just talking about the two different types of strokes and how they present. So talking about ischemic strokes, this is caused by a literal occlusion in the brain, okay? So something is blocking that blood flow, whether that is most commonly a blood clot, or it might be some type of plaque buildup or a spasm of that artery or blood vessel, which is a less common side effect. Most of the time it's going to be due to a clot, but there are still other things that can affect it. Around 87% of these strokes are considered to be ischemic, and that's also coming from the Center for Disease Control and their research data. So that's the large portion of those, right? So that leaves about, 13% to be hemorrhagic strokes. But 87% is a large number, and there's a lot of things that we can do, risk factors that we can look at and eliminate to determine our risk for an ischemic stroke. All right, so this may be prefaced by a mini stroke or a TIAA, which we're going to look at on the next slide, that TIAA being a transient ischemic attack. But that is unique for that ischemic stroke because a hemorrhagic stroke cannot be prefaced by a TIAA, so that's a significant factor for you to remember. So looking at hemorrhagic strokes, these are caused by bleeding in the brain, and different things can cause that bleeding. One of the biggest reasons would be uncontrolled hypertension or high blood pressure for a long period of time that causes an aneurysm to form inside of the brain, and then rupture of that aneurysm can cause that bleeding. And this might be inside of the brain itself, it might be above the brain, but either way, your signs and symptoms might be exactly the same. Another big reason that someone might have a hemorrhagic stroke might be from a head injury, and that could affect any age range because we're looking at here either blunt or penetrating trauma to the brain, and this could be caused or made worse by someone who takes a blood thinning medication or a platelet aggregator, something like aspirin. That seems very simple, and we know a lot of people that take aspirin on a daily basis. That's a very common medication, but your chances of having an actual bleed inside of the brain if you take an aspirin and you have a head injury are exponentially larger. So what is a mini stroke? We mentioned that just a second ago. So a mini stroke, or a TIAA, which is a transient ischemic attack, that can preface an ischemic stroke. And so the symptoms here are going to be exactly the same as they're going to be for either our ischemic or hemorrhagic strokes as well. And we're going to look at that here in just a second. But the symptoms are going to present exactly the same. There's not some big red flag that pops up and says, hey, I'm a mini stroke, this isn't a big deal. What do we classify that as? A TIAA is going to be that the symptoms resolve within about a 24-hour time frame. Now, do we know at minute 1 or hour 1 that these symptoms start, that this is going to resolve in 24 hours? Absolutely not. So our treatment and the reaction that we have to those TIAA symptoms should be exactly the same, because we can't tell the difference in the field. Just like we can't tell the difference between an ischemic and a hemorrhagic stroke in the field. We might have something that can clue us in, whether it be that obvious head injury that lets us think this is probably a hemorrhagic stroke, or whether we look at someone who has a clotting disorder or who lives a sedentary lifestyle, has had a recent surgery, something along those lines that might lead us to believe that this is an ischemic stroke as they're more prone for a blood clot. But there's nothing that we can use, no definitive test in the field that can determine that. What we have to wait for is that CT scan at the hospital. And so our treatment is going to be exactly the same. Our response time going to be exactly the same. So signs and symptoms, like we talked about, for all of our strokes, both ischemic, both hemorrhagic, and also TIAA. That's going to bring us to this slide here, taking a look at some of the most common signs and symptoms. Now, every single patient might not have all of these signs. No patient is probably going to present like a textbook stroke. They're probably not going to have every single thing listed here, but rather a combination of some of them. So some signs and symptoms that we might see might be a headache, blurred vision, loss of balance or coordination, and sometimes those things can start very early on, but ultimately the deciding factors that we use to determine that the patient is having a stroke and what we're looking for in our stroke screen is going to be that altered mental status or slurred speech, facial drooping, and then unilateral weakness or paralysis. And so we're going to take a look at that here in just a second as we move forward to the different types of stroke screens. So the two most common pre-hospital stroke screens are going to be the Cincinnati stroke scale and the Los Angeles pre-hospital stroke screen. Okay, most people, and I'll tell you this up front, most people don't use one or the other. Most people use a combination of both, and that's okay because it has to be a tool that you are using to determine if this patient is having a stroke. Some agencies might require that you do one versus the other per their protocol, but most are going to be pretty responsive to whichever criteria you determine they're using. And as we dive into this, you'll see that the Los Angeles is a little bit more constricting in its requirements because you have to meet all of the requirements listed there. But let's talk about the Cincinnati for just a second. The things that we're doing here are looking for facial droop, arm drift, and paying attention to the patient's speech. So if I'm assessing a patient's facial droop, I would approach that patient, I would ask them to smile for me and show me their teeth. Okay, so as that patient prepares to smile, we should see, ideally, both sides of the mouth go up at the same time. If we were to see only one side go up, that would let us know that they had facial drooping on either the right or left side. That would be a positive finding for this stroke screening. With the arm drift, same thing. We would ask the patient to place both arms out straight in front of them, just like this, and then we would ask them to close their eyes. And if they close their eyes and both arms stay up, most likely they're not having a stroke. If one arm begins to fall or drift, and it could be slow or rapid, but if one drifts a lot in comparison to the other, that's a positive finding. With the speech, here we're looking for slurring of the speech, but also paying attention to confusion. So is the patient apparently having a hard time thinking about what they want to say, or are they having a hard time understanding what you're saying? And so here we're looking to see, have them say a simple phrase, like you can't teach an old dog new tricks. Okay, so when we have those types of things that they can't say or that they're having to really think about to get it out, that would be a positive finding. With the Los Angeles stroke scale, this is also looking for a couple of those things. It's assessing the facial droop the same way, arm drift the same way. The other criteria that they use here is the arm grip. And so here we would have the patient squeeze both of our hands with both of theirs. And so by assessing this at the same time, we're looking to see, are they weak or completely flaccid or paralyzed on one side or the other? And that will give us some indication that this patient is experiencing a stroke. Also looking at the Los Angeles stroke screening, you can see that they add some more inclusive material. The patient does have to be over 45 years old. They can't have a prior history of seizures. The onset of symptoms must be within the past 24 hours. They had to be ambulatory prior to the incident beginning. And their blood sugar also has to be between 60 and 400. So we can see that we're putting some limits on what we're doing here with that particular screening. And so that's just potentially a reason why someone might choose the Cincinnati over the Los Angeles. But it's important that you know that both stroke screenings are essentially tools, and they are both effective means to determine that a patient is having a stroke. And they don't have to be positive for all of that criteria. They do have to meet all of those requirements on the Los Angeles, the age, blood sugar, things like that. But as far as the findings of the facial drooping, the slurred speech, the grip or the arm drift, those things, if they are positive on one of those, then they could be experiencing a stroke, and we would want to go through the proper channels for that and transport them to an appropriate facility, which would be a stroke capable facility. We also have to think about some things that we can rule out. So Looking at hypoglycemia, we talked about that blood sugar being between 60 and 400. Hypoglycemia can mimic signs and symptoms of a stroke, and we're familiar with that. Also, did the person have a stroke before? Because that neurologic deficit that's left over could be what's causing this. So we need to know what their normal and baseline is. Using the FAST mnemonic, this is something that's very similar to the Cincinnati stroke screening, and looking here at the person's face, arms, speech, and then the last one there being time. So it's important that as soon as we recognize these symptoms, we're attempting to get the patient to the correct facility by calling 911. So we want you to take this information and pass that on to friends and family members, because that's super important. We don't want someone to say, well, grandma's just acting kind of crazy today, she's having trouble talking. We want them to know that that's not normal and they should call 911. So thank you guys for your time and attention. I really appreciate it.